It's live now. So let me share the screen first. I'll introduce you, then we'll proceed.
Sure. Okay.
Good evening, ladies and gentlemen, those who have connected today with us over our Core Connect platform group. Today, I'm happy and very happy to introduce you all to the Banker IVF Women Hospital's present webinar series on up-to-date guidelines-based fertility treatment. Episode 3 on recurrent pregnancy loss by Dr. Manish Banker sir in association with Corona Remedies. This is Piyush Shukla from Corona Remedies, again welcoming you all. And as per the tradition goes, let's start the program with the lamp lighting ceremony. Today, I feel privileged and proud to introduce you all with one of the mostly known person, Dr. Manish Banker, sir. The person needs no introduction, but yet I'd like to mention few of the his major achievements, which are he's director of Banker IVF and Women's Hospital. He's been awarded by Dr. B.C. Roy Award by Medical Council of India for the year 2017. He's been past President SR 2012 to 2014, Regional Representative International Committee for Monitoring ART, ICMART, Senior Associate Editor, Journal of Human Reproductive Sciences, Member Board of Director, Poseidon Group, Member Surveillance Editorial Board, IFS 2011, 14, 17, and 20 respectively. Member Board of Director, Pacific Rim Society of Reproductive Medicines, Founder Board Member Aspire, Member Draft Committee for Art Bill of India, ICMR, in Ministry of Health, India. A very warm welcome, sir. And I'd like to, because a lot of people are very waiting to hear from you, I'd like to hand over the session to you. Very welcome, sir.
Thank you very much. It is indeed a pleasure to be a part of this. And we start with the third episode of the webinar series on evidence-based fertility practice. Now, today's topic for discussion is recurrent pregnancy loss. The talk is primarily based on this ASHRAE guidelines, but I will include evidence from a lot of other publications as well, because we want it to be more inclusive and up to date with whatever information that we have. So over the next 45 minutes or so, I will take you through the various definitions, the risk factors involved in this condition, and the investigations and eventually treatment for recurrent pregnancy loss. So the incidence of early pregnancy loss is very difficult to determine accurately because nearly 60% of pregnancy losses are preclinical losses, that is, before a pregnancy can be clinically recognized. And this would mean either an implantation failure or a very early biochemical pregnancy loss. So nearly 70% of the conceptions are lost even prior to the occurrence of a live birth. The clinically recognized miscarriages are somewhere around 10%. And this miscarriage is currently defined as a loss of pregnancy before 20 weeks of gestation. Now, the pregnancy as far as a miscarriage is concerned, should be confirmed by at least a serum or a urinary beta-HCG. And it also includes non-visualized pregnancy losses in the form of biochemical pregnancies or resolved and treated pregnancies of unknown location. That is where you find that the beta HCG is positive, but you are unable to locate the exact position of that particular pregnancy. However, for recurrent pregnancy losses, an ectopic or a molar pregnancy or an implantation failure is excluded from this particular definition. Now, numerous countries and organizations define this in different manners. So, in the UK, if you look at the RCOG guidelines, 3 or more consecutive pregnancy losses are what is recommended. If you look at the practice committee of American Society for Reproductive Medicine, it is 2 or more pregnancy losses. And if you look at the WHO definition, it includes includes all losses where the fetus is weighing less than 500 grams or is between 20 and 22 weeks. But the latest definition, as proposed by ESHRE in 2018, includes diagnosis of recurrent pregnancy loss should be considered after the loss of 2 or more pregnancies, both either after a spontaneous conception or after any kind of infertility management. And this should include all pregnancy losses from the time of conception until 24 weeks of gestation. So it is 2 or more pregnancies and right up to 24 weeks of gestation. Now, this could be primary RPL, which means the patient has never had a pregnancy going beyond 24 weeks, or secondary RPL when the patient has had at least one pregnancy which has grown beyond 24 weeks. The rough prevalence believed is somewhere between 1 to 2% of women. So the American Society defines it as 20 weeks or 500 grams, whereas ESHRE puts it at 24 weeks. So slight difference in the definition. So if you look at the RCOG, ASRM, and the ESHRE guidelines, and I think we should now focus more on the ESHRE because it is the latest, is that there should be 2 or more pregnancy losses. They need not be consecutive. You could have a live birth or an ongoing pregnancy beyond 24 weeks between the miscarriages. It should be a confirmation by a serum or a urinary chorionic gonadotrophin. So biochemical pregnancies would get included in this. However, one will not include ectopic or molar pregnancies. As I had mentioned earlier, the GDG guidelines includes reserves recurrent miscarriages to only those where an intrauterine pregnancy has been confirmed, but this is from older times. And we now look at only a positive beta HCG level. Now, clinical investigation should definitely be started when there are 2 or more consecutive abortions. However, we should do it maybe earlier or more so when the fetal cardiac activity has been identified prior to the pregnancy loss, or when the woman is elderly, or when the couple is having problems in conceiving and they've conceived after considerable treatment. So in these instances, on a case-to-case basis, one could start investigations at an earlier stage. Now, there is no clear consensus regarding the prevalence, but as I had mentioned earlier, most case series reports it between somewhere between 5 to 5% of the couple. And the reason behind this is that in all spontaneous conceptions, it is very difficult to estimate the incidence of a biochemical loss because these patients will not come for pregnancy tests or monitoring at a very early stage where a biochemical pregnancy could be detected. However, it seems that there is a global rise in sporadic pregnancy losses and in recurrent pregnancy losses because of advanced age at which a woman considers having a pregnancy, in addition to other lifestyle issues and environmental issues. And let us look at this in slightly more detail. So if you look at this table and try to give the prognosis to a patient regarding what is the risk of a miscarriage for you. So in a patient who has at least one live birth, that means it is a secondary kind of a pregnancy loss. She's had one previous live birth. The background risk is around 12%. If the woman has had one more miscarriage after a live birth, this doubles to around 24% and it plateaus at around 45%. Whereas in a woman who has never had a live birth but has two or more losses, the risk in a subsequent pregnancy is around 40 to 45%. However, if you look at this from another angle, it means that in a patient with recurrent pregnancy loss, she has a nearly 55 to 60% chances that the subsequent pregnancy will not end in a miscarriage. So it depends on how you counsel the patient. We also know from the general data that 80% of spontaneous abortions occur in the first trimester of the pregnancy. And out of this, nearly 70% are due to some or the other chromosomal abnormality. Now, once the fetal heartbeat is located, this rate drops significantly to around 5%. So the first hurdle that we should be looking for in a patient with history of pregnancy loss is the appearance of fetal heartbeat, because that sign itself leads to a significant reduction in the loss of that particular pregnancy. Now, there are numerous causes for this condition, both from the maternal side in terms of uterine infections, maternal disease, immunological or endocrinal, or fetal or embryonic causes in the form of chromosomal or structural abnormalities. And the list is fairly complex. So you could have genetic factors, anatomical, endocrine, infectious, immunological, etc., etc. And in nearly 45%, we are unable to find a specific cause for the miscarriage, and this falls in the category of idiopathic recurrent pregnancy loss. So this tells us that the investigative approach to this condition is challenging, and we should follow a logical path in the treatment of this, because it is a heterogeneous condition. Pathogenesis is many a times multifactorial, it is complex, and is also poorly understood. And standard investigations may help us in nearly 50% of the cases, but there could be a lot of other variables. So how do we start investigating a couple with recurrent pregnancy loss? First, you start after two losses, but you could start earlier if the patient is elderly, has known medical disorders, has a known family history. You follow the principle that you investigate the common and the treatable causes first. We should not order a blind screen, which would include all the tests available under the sun for recurrent pregnancy loss. And for this, many times you need to use your common sense. So this individualized approach to recurrent pregnancy loss should be based on how old the patient is, whether she has history of infertility treatment or not, what is the pregnancy history, at what age of pregnancy did the losses occur, was the fetal heartbeat seen or not, is there any family history of the condition, does the patient have history of previous live births followed by miscarriages or not, and what all investigations or treatments the patient has already undergone. So this forms the basis on which you tailor an individualized approach, and we should also look at providing the patient psychological support. So investigations do not necessarily lead to a treatment option, and we should counsel the patient about this, that in spite of all the available investigations in our mind, we still may not be able to identify the cause, because we need to set the expectations right in these patients who are already under tremendous stress. So first is to individualize the treatment, don't make it very complex. And second, counsel the patient about what you're doing and what are the chances of your finding a reasonable cure for this condition. So you begin with a detailed history like you do for any other patient. You ask for family history as well. And there are certain possible causes which you will be able to know simply from the history. Family history will tell you whether the disease runs in the family. You ask for specific high risk factors like history of smoking, exposure to anesthetic gases. You look at the patient's occupation, whether the patient is exposed to toxins, chemicals, etc. So all the environmental and the family history are essentially diagnosed by taking a very detailed history. You will also try to find out at what stage the pregnancy losses happened. Did they happen before the appearance of the gestational sac? Did they happen after the appearance of gestational sac, but before the appearance of cardiac activity? Or did they happen after the appearance of cardiac activity? Did they happen in the first trimester or in the second trimester? And how did the whole event of miscarriage happen? So this will, in a large number of cases, give you a pointer as to in which direction should you start investigating the patient. Amongst the environmental factors, we know that there are certain issues which have a confirmed association with pregnancy losses, and this is exposure to ionizing radiations, organic solvents, high degree of alcohol intake, or heavy metal poisoning. There is also a higher risk if the patient is taking high amount of caffeine, is a chronic smoker, active or passive, or has history of hyperthermia or fever during the pregnancy. The association between pesticides, insecticides, various fertilizers is yet not very well established. You then move to a complete clinical examination followed by transvaginal sonography, because all anatomical factors, if not conclusively diagnosed, at least you would have a fair amount of suspicion only on the basis of your clinical examination and a good transvaginal ultrasound. And this could include various congenital factors like Mullerian anomalies, septate uterus, unicornuate, bicornuate, etc., or acquired pathologies like tumors, fibroids, polyps, synecdoche, bands of adhesions, or cervical incompetence. Now, amongst this, there are certain factors which are potentially correctable or relevant, and this would include a septate uterus, a bicorporeal uterus with single or double cervix, or a hemiuterus. And this prevalence of uterine malformation is higher in a woman who has a history of recurrent pregnancy loss at around 13.3% versus its prevalence in the general population. So you find a congenital abnormality, it immediately tells you that this could be the possible reason behind this. Now, nearly 10 to 15% of recurrent first trimester losses, more so after the appearance of the fetal heartbeat, are because of a congenital anomaly in the uterus. And variations of double uterus are more common. Now, septate uterus accounts for nearly 25 to 40% of this, and this is amenable to treatment. Whereas in bicornuate pregnancy, the losses may account to 40%, but the benefit of surgery are extremely debatable. If you have any doubt with the help of ultrasonography alone, you could do a sonography, you could do a sonosalpingography, you could do a hysterosalpingography, you could do a hysteroleproscopy, which would give you an opportunity to do treatment as well, or you could do a MRI. And in all patients who have a uterine malformation, you should look for urinary tract malformations because they many a time coexist. So the ASHRAE guidelines tell us that all women with recurrent pregnancy loss should have an assessment with an ultrasound. A 3D ultrasound is much more sensitive in diagnosing problems. Sonosalpingography, HSG, both could be done. You could combine the sonohistogram with a 3D also. If you have a doubt or if these are not conclusive, you could carry out a MRI. But at least all patients should have a good transvaginal ultrasound. Now, when the history and the clinical examinations are completely normal, you then look for these four. That is infections, endocrine factors, immunological factors, male factors, and genetic factors. And let us see how do we go about this. Now, for infections, the organisms responsible are primarily chlamydia, ureaplasma, mycoplasma, and toxoplasma. But we must remember that all these infections may cause sporadic abortions because of the bacteremia or a viremia. A bacterial vaginosis in the first trimester may even cause a loss in the second trimester or may result in a preterm loss. But there is no role of empirical treatment just on the history of previous losses. Now, for any infective agent to be implicated in RPL, that infective agent must be capable of persisting in the genital tract and must cause insufficient symptoms, otherwise it would be very apparently symptomatic. Now, if you look at the TORCH test, which is fairly commonly carried out in patients with recurrent pregnancy loss, it does not fulfill this criteria because any of these infections can cause one or a sporadic pregnancy loss, but it is unlikely that that infection remains active or persists in the active form throughout multiple pregnancies. And hence, RCOG guidelines mention that TORCH testing should be abandoned as a part of RPL investigations. And hence, serial titers or unnecessary treatment for these conditions is not required. I once again mention that this can cause an abortion, but you cannot have these infections persist to cause recurrent pregnancy losses. So essentially, no infectious agent has been proven to cause recurrent pregnancy losses. Chronic endometritis, many a times now implicated for recurrent implantation failure, but for recurrent pregnancy loss, we still don't know. However, some people believe that it might be cost effective to simply give a course empirical of an antibiotic, either doxycycline or erythromycin, for a period of 2 weeks to take care of any possible infective agent. Then we move on to the various endocrinal causes. And here again, history, clinical examination are of great value. The conditions which one should specifically look for is poorly controlled diabetes, thyroid either hypo or hyper, hyperprolactinemia, and a luteal phase defect. So a poorly controlled diabetes could lead to both early as well as late pregnancy losses. And this is primarily because of the hyperglycemia leading to vascular disease and aggravating possibly the various immunological factors, apart from altering or leading to a genetic interference. Thyroid screening, both TSH and TPO antibodies, is recommended in women with RPL. Abnormal TSH or a positive TPO titer should be followed up by thyroxine testing. Testing for PCOS or fasting insulin and fasting glucose is not recommended to improve the outcomes in RPL. And same in a patient who is asymptomatic, has regular cycles, prolactin testing is also not recommended in RPL. But thyroid is something which is a must. It is very strongly recommended that you test the patient for TSH and TPO antibodies. And if you find the presence of subclinical or clinical hypothyroidism, you must treat that particular patient. PCOS, fasting insulin, and fasting glucose is generally not recommended in patients with RPL to improve the prognosis in the next particular pregnancy. Similar with prolactin, that if the patient does not have symptoms of hyperprolactinemia in the form of galacturia, oligomenorrhea, or amenorrhea, there is not consistent evidence. There are very few studies, but these are of poor quality. Amongst the other tests for ovarian reserve, not recommended. Luteal phase insufficiency, not recommended, because this can cause one particular pregnancy loss, but it cannot cause recurrent pregnancy loss. And similarly, any form of androgen testing is also not recommended for pregnancy loss. So the only test which is possibly recommended amongst all this is testing for vitamin D and possibly for homocysteine, and then correcting the patient's B12 and vitamin D level if you find that there are problems. We then move on to a very relevant cause for recurrent pregnancy loss, and that is immunological causes. Now, patients who have recurrent pregnancy loss because of an immunological problem have very typical characteristics. They will have previous spontaneous abortions. They will not have a recent full-term pregnancy. So they could have had a full-term, but generally it will precede the abortions. She would be a young patient. If a conceptus has been subjected to a karyotype, it would typically be normal. And generally, she will have history of at least one pregnancy which has gone beyond the first trimester. Unlike chromosomal problems where most pregnancies are likely to abort very early, these are fairly late miscarriages, with some of the pregnancies going beyond the first trimester. And this is because of the various thrombophilias. So pregnancy is essentially a hypercoagulable state, and patients who have a hereditary or an acquired thrombophilia have a higher risk of a pregnancy loss. So the hereditary could be factor 5 Leading, protein C, protein S, antithrombin 3 deficiency, the MTFR mutation or prothrombin mutation. And amongst the acquired, you could have the lupus or the anticardiolipin or the alpha beta 2 gamma P antibodies. So how do you diagnose the antiphospholipid syndrome? You should have either clinical features in the form of some evidence of vascular thrombosis, or there should be a loss of fetus at 10 weeks or later, or a preterm delivery, or she could have 3 or more consecutive spontaneous abortions before 10 weeks. So there are multiple pointers towards this. And if you're doing a laboratory testing, they should have high levels of anticardiolipin or lupus antibodies detected on 2 occasions, at least 6 weeks apart. So a single elevated level also does not confirm this. So there are fairly strict criteria for diagnosing the antiphospholipid syndrome. It is amongst the most easily treatable cause of RPL and is present in nearly 10 to 15% of patients with recurrent pregnancy loss, as opposed to 2% in normal. And if you don't treat it, only less than 10% will end up with a live birth. But if you treat it, the success rate are as good as any. The other antibodies are not associated with recurrent pregnancy loss. So anti-nuclear antibodies, anti-thyroglobulin antibodies, these are all not recommended to be tested. So the screening for this is lupus anticoagulant, anticardiolipin antibodies, alpha beta 2 glycoproteins. It is not yet clear whether you should test for hereditary thrombophilias in all patients. And as I had mentioned earlier, testing for HLA, cytokines, NK cells, anti-HLA antibodies, etc., is certainly not recommended. So what the ASHRAE guidelines mention is that we test for hereditary thrombophilia if there is a presence of a very strong family history and there is a family member who has this particular deficiencies. Otherwise, it is not recommended. But acquired, you would test by doing a lupus anticoagulant, anticardiolipin antibody, and beta-2 glycoprotein antibodies. These 3 testing is must if the patient satisfies the clinical or the laboratory criteria for the various thrombophilias. So for acquired thrombophilias, you must test the patient. And if you're relying on laboratory investigations, you should have 2 tests done at an interval of 6 weeks. And all these other tests, as I had mentioned, are not recommended. We then move on to the last, but a very major chunk, and that is the genetic factors. Now, you could have numerical abnormalities in the form of a trisomy, that is one chromosome extra, or a monosomy, that is one chromosome less, or sometimes it could be triploidy, that is one full set of 23 chromosomes. And in this instance, 90% of this is inherited from the father, very rarely tetraploidy, and sometimes mosaicism. But a very important is the various translocations. Now, the most common cause amongst the genetic, and if you're looking at karyotype, is a balanced translocation. This means that either the husband or the wife, whoever has that balanced translocation, is asymptomatic because the total genetic material is adequate or is the same in that particular individual. It is only that the genetic material is translocated from one chromosome to another chromosome. Now, this is more, the spontaneous losses amongst patients with translocations are common if it is a reciprocal translocation or an inversion versus a Robertsonian translocation. And the chances of pregnancy recurrent loss, if one partner has a balanced translocation, nearly 30% of the pregnancies would end up with abnormalities. The other impact when we look at the genetic factor is advanced maternal age, because as the mother's age increases, the incidence of aneuploidy, especially maternally derived trisomies, keeps on increasing. And this is essentially because of poor quality of oocytes. Because oocytes recruited later in life are more likely to have some or the other abnormality, or they might experience a meiotic error. And as the age increases beyond 35 and more so after 40, the incidence of miscarriage increases significantly. Now let us look at this translocation, because this is something which is very easily treatable. So there are 2 types of translocations. One is a balanced and the other is a Robertsonian. So if you look at the left figure of the balanced translocation, it is only one part of the chromosome which gets moved to another location. So in the picture, you see that the green part that is of the long arm gets translocated into the red part of the wrong, and the red part gets located into this. So there is only a switch of the chromosome. In the Robertsonian translocation, it is different. The entire fragment gets attached to that particular chromosome. So when you have this kind of translocation, and when there is subsequent meiosis and a formation of an embryo, the resulting embryo does not have the balanced genetic material, and hence it ends up in a miscarriage. So should you do a karyotype of the abortus? Now, this is optional, but it guides only in the index case. It does not explain everything, because if you test a particular abortus, it will give you the reason in that particular abortus. However, if the abortus shows that there is an unbalanced translocation, then you should test the parents to see whether they are balanced carriers. But if you find simple trisomies, it may not necessarily be the cause for recurrent abortions. So what do you do here? If there is a first miscarriage, you don't do anything. But for the second or the subsequent, you obtain the POC. If it is euploid, the karyotype shows that the pregnancy did not have any genetic problem. Then you look at the other causes. If it shows there is an unbalanced translocation, you look at the parental karyotype and see whether there is any balanced translocation in the either of the parent. So the genetic analysis of the pregnancy tissue, which will tell us whether that particular embryo was genetically abnormal or normal. This, if you do by conventional karyotyping, you will be able to differentiate all the 23 pairs of chromosome, but sometimes it does not, it needs dividing cells. Secondly, it is many a times difficult if there is maternal contamination. So generally, when you're testing the product of conception, we suggest a microarray because one, it does not need dividing cells, and two, you will be able to detect the various translocations which you will not be able to see in the karyotype. So array CGH is better, or you could do the next generation sequencing when you're looking at the products of conception. So for the pregnancy tissue, you would do not routinely recommended, but it will give you an explanation. And if you're doing, you do the microarrays and not a karyotype on the product of conception. Whereas on the parents, you need to do a karyotype, and you will find that the karyotype is abnormal in nearly 2 to 4% of the patients. And you would recommend this if there is history of a previous child with an abnormality, or there is a product of conception report which shows an unbalanced translocation or any kind of translocation, or there is history of RPL in a first degree relative, then also you would test the parents. So parental testing is recommended on an individual basis. What about the male then? Now, there is very little conclusive evidence between the contribution of the male to recurrent pregnancy loss. Obviously, there has to be a relation. It cannot be that the male is not responsible, but we have very limited tests, apart from a karyotype, which if it shows any abnormality. What about the DNA fragmentation test? Now, there are some studies which show that there is an increase in miscarriage rates in men who have high sperm DNA damage. A subgroup analysis also showed that this association is strongest if you do the tunnel assay. So there is some evidence that high DNA fragmentation leads to high miscarriages. But since there is not completely clear evidence, what ASHRAE recommends is that you should recommend lifestyle changes. So if the husband is smoking, his alcohol consumption is high, has got a high BMI, is living a sedentary life, you should recommend lifestyle changes, because the primary treatment for all DNA damage is ultimately improving the lifestyle and giving good antioxidants. After you have exhausted this whole study, one would find that in nearly 50% of the couples, you are unable to find an explanation as to why the pregnancy loss has happened. It is here where your counseling is important, that in patients who have unexplained recurrent pregnancy loss, when you have ruled out all the causes, especially the uterine, immunological, and the genetic, nearly 70% live birth rate is reported in this patients of unexplained RPL who have an untreated subsequent pregnancy. So even if you don't treat them after you have ruled out all the possible causes, 70% of these pregnancies will lead to a live birth rate. So keeping this in mind, now how do we offer treatment? So the treatment should be based on certain criteria, and there are a few charts which give the patient a prognosis based on the patient's age and the number of miscarriages. However, let us see how do we go about this. One of the commonest treatment that is today being offered in patients with recurrent pregnancy loss is to do a pre-implantation genetic testing on the embryo and see whether the embryo is euploid. But if you look at in patients with unexplained RPL, where no specific cause has been found, PGTA has shown to be not superior to expectant management. However, when you have a specific genetic factor, most importantly, the structural rearrangements, or when there is advanced maternal age, etc. It is here that PGTA, aneuploidy screening if it is advanced maternal age, M monogenic if there is a specific gene defect, or SR if there is a structural rearrangement. This would be the treatment of choice. So all patients who have an abnormal fetal or parental karyotype should be subjected to exhaustive genetic counseling. And we need more evidences to look at the value of PGTA in patients who have unexplained recurrent pregnancy losses. Amongst the thrombophilias hereditary, if the patient does not have specific history, then there is no benefit of giving this patients aspirin, low molecular weight, or heparin. So in patients with a hereditary thrombophilia and history of RPL, the ASHRAE guidelines suggest that we should not offer them antithrombotic prophylaxis. However, in all patients with acquired thrombophilias, that is, you have tested for antiphospholipid syndrome and they are positive, they require treatment with aspirin, which is started before conception, and low molecular weight heparin, which is started from the day of the positive pregnancy test. So you start aspirin pre-conception, but the heparin is started once the pregnancy is confirmed. There is very little evidence supporting the use of intravenous immunoglobulins or steroids in any form. In patients who have endocrinal problems, overt or subclinical hypothyroidism, the treatment of choice is thyroxine. And patients who have autoimmunity to thyroid, again, low dose of thyroxine would be the treatment of choice. If the patient has a uterine congenital abnormality, other than a septate uterus, there is no evidence that correction of any other congenital abnormality helps in improving the outcome. But if the patient has a septum, you should remove the septum. So look at the ASHRAE guidelines. There are very few RCTs which shows no benefit, but by and large, a septate uterus is removed. Metroplasty, however, is not recommended. Uterine reconstruction for Didelphys uterus is also not recommended. In patients who have acquired deficiencies, for example, intracavitary pathologies, even though there are not multiple studies, there is a conditional approval that you need to correct intracavitary pathologies in treatment of recurrent pregnancy loss. Cervical incompetence obviously needs treatment. So patients who have history of a second trimester pregnancy loss with cervical weakness should be subjected to a cerclage. For male factor, as I had mentioned earlier, the only treatment recommended is lifestyle changes, give up smoking, lose weight, limit alcohol consumption, give a normal exercise pattern, and give the patient a good antioxidant. However, if you look at this particular small study, antioxidants did not improve the outcome in subfertile man. What about the host of add-ons? Now, this is a very, very long list. Lid therapy, intravenous immunoglobulin, steroids, folic acid, progesterone, intralipid, GCSF, scratching, so on and so forth. If you look at the ASHRAE guidelines, none of this are of any benefit. So neither lid therapy, nor intravenous immunoglobulin, nor steroids, nor heparin or aspirin on an empirical basis, GCSF or scratching. None of this has shown to be of any benefit in treating recurrent pregnancy loss. And we must remember that these patients have limited financial resources to them. And if you offer them high-tech treatment, which come at a cost, but the success rate is not proven, it adds to the cost and also it adds to the patient's stress. So there is very limited role of all of these add-ons in treating a patient with recurrent pregnancy loss. This then brings us to the last category of unexplained recurrent pregnancy loss. Is there any role of vaginal progesterone? Some evidence that giving vaginal progesterone may improve the live birth in patients who have 3 or more pregnancy losses. Low-dose folic acid is also to be started preconceptionally, especially to prevent neural tube defect, but it is not for an unexplained pregnancy loss. So there is very little evidence, but this is something which is not uncommonly done. Preconceptional folic acid and low-dose vaginal progesterone. So this is how the whole algorithm for recurrent pregnancy loss looks. We have certain tests and treatments which are recommended. As I mentioned, the first among them is immunological testing because you have a definite treatment, thyroid because you have a definite treatment, uterine abnormalities, especially septum because there is definite treatment. Genetic testing, it depends on what you find and when the pregnancy losses were there. Sperm DNA fragmentation, hereditary thrombophilia, and rest of the others are not really recommended. And if you don't find anything, ultimately it is lifestyle advice, tender loving care, prophylactic folic acid, and vitamin D. With this, I come to the end of my talk. I thank you all and I open the session for questions.
Thank you so much, sir. Please give me 1 minute. Let me check. Is there any question posted over our platform or not? So they are just thoughts only of people like Dr. Bhavana. She is from Mysore, and she's saying that it was a really wonderful talk. Hope to see you in the next webinar again. Dr. Richa and Dr. Shobna both are appreciating again. And there are a few more comments, but everybody is appreciating only and looking forward to the next talks. Thank you so much, sir. If we'll get any kind of questions, we'll surely mail to you.
Thank you very much.
Thank you so much, sir. Have a
Thank
great day. Have a great day.